I came into healthcare to make a change, and I want to do so at scale. And we're now working with over 20 hospital systems, and these are the largest ones in the country.
Welcome back to the Chilmark Research Channel. Today we are broadcasting from HIMSS 22, and I am going to be interviewing Mike McSherry, the CEO and co-founder of Xealth. But before we jump into things, please remember to subscribe to our channel so you receive updates when we post new content. And if you like what you see here, please leave us a like or a comment. So to start things off, Mike, I know that you come from a background of tech entrepreneurship, as many people in this building do, but you took time in between to actually learn, really embed yourself in healthcare. So what drove you to take that leap to get into healthcare, but also embed yourself in Providence to actually really learn more about all the different nuances of being at the front lines of care delivery?
I've done several tech startups, Xealth being my sixth company I've co-founded. And I sold my last company to Nuance, and though it was in the mobile space, but I got exposed a little bit to Nuance's dragon business and their healthcare business. As I was leaving Nuance, contemplating my next startup, I had also joined the board of a hospital system in Seattle that merged with Providence. And so I met the CEO of Providence, and he convinced me to think of doing a healthcare startup. And so as I was contemplating different paths, I'm like, well, what better way to learn the industry than being inside of an organization? He invited me in to be an entrepreneur in resident with my former executive team. So it gave us a green light to think of different problems in healthcare.
Yep.
I jokingly called it the free range EIRs. And we cycled through 70 different ideas, illegal, immoral, nobody will pay for, won't work. And eventually we came to understand some of the problems and dynamics of the hospital operation and realized that would be a big opportunity of a business. So we incubated inside of Providence and then spun it out.
Okay. So what did you learn? You said that there were all these other projects that you went through that ended up not being viable for whatever reason.
Yep.
But beyond that, what else did you learn about how the healthcare system works that's inspired you and driven what you're doing with Xealth?
Well, certainly understanding how clinicians, doctors, nurses, MAs, they carry the workload of the health and safety of this country on their backs,
Yep.
And especially as we've seen during COVID. And so you get inspired by that, and yet you also see all their manual processes and their laboriously, kind of level of efforts where digital and technology automation does not help them or does not quite come to them yet.
Yep.
A lot of it is economic and business model and other incentives. But in the case of Providence, we realized we could help them solve a problem, and that this is a wide-scale problem for other systems, so a big enough opportunity for us to carry it forth as a business endeavor and raise money and grow a business off of that opportunity.
Okay, so let's talk a little bit about what Xealth does. Everybody's been trying to figure out how to incorporate mobile health and apps into the daily lives of patients, but also have that work well with the hospital systems.
Yep.
So tell me a little bit about how you are addressing that issue and what some of the unique problems are that Xealth addresses that maybe a Haptique or some of these other attempts to do this in the past weren't able to actually accomplish.
Yeah. So let me back up regarding the mobile. I co-founded Boost Mobile, which is now Dish's nationwide prepaid service. I also co-founded a company called Swype, a touchscreen keyboard that was put on several billion phones. And so tremendous mobile experience. And we thought bringing some of that mobile capabilities, endeavor, technology to the healthcare consumers, the healthcare patients in a more seamless, beneficial and kind of ability for them to take action on healthy daily habits and lives would transcend a better care model and better care quality. So with that insight, we saw that there were a range of different digital apps and tools and devices and services and content that was largely being verbally referred to the patient. Oh, go to the app store and download that app. Or here's a brochure about that app. Or here's a photocopied piece of paper on your rehab exercises. And we thought just digitizing all of that and letting the clinicians easily prescribe that asset to a patient, deliver it to the patient in a seamless, consistent manner, and then track if the patient read it, watched it, what that app is saying around their A1C or their behavioral health screenings or their glucometer readings or their CPAP device data. Yep. Just bringing all that back in the workflow for the clinician to interpret, change care plans, understand dynamics of is this working for the patient or do we need to do a different care protocol. So that's what we built, is a seamless mechanism to prescribe any digital asset to a patient and then track the patient's usage and engagement of that. And we don't choose the tool. The hospital system deems what tool might be appropriate, be it a maternity care app or a diabetes management app, or the Lyft ride to get the patient on, to the procedure on time, or the meal delivery for post-op recovery if someone doesn't have a caregiver at home. So we've integrated 60 different things for our hospital customers, but we put it in a seamless workflow that saves ITIS cost and money, activates the patients more readily, and brings all the monitoring of that activity back into the clinical workflow for analytics and interpretation and better care delivery.
Yep.
So that's what we built.
Okay, fantastic. So I don't know if you know this about me, but I actually did have a mobile health startup before I joined Chilmark Research. It was premature. This was back in the early 2010s. And I was trying to do something around mental health space where people could have a live journal where they track their symptoms and whether or not they're adhering to different parts of their treatment, not just their medication regimen. But it was too early for the market at that point. Everybody was focused on the EHR deployment at that time, and they're just trying to deal with the change management of that. However, I have noticed that there still hasn't been a huge uptake of mobile health within the healthcare system yet. And so I want to get your take on, is that because of a resistance to these new technologies and letting go of some of that control of the patient encounter? Or is it just a lack of maturity? And now that we're a little bit more of a mature market, you're starting to see more adoption of these tools.
Great question. I think there are a couple of things. So when we were incubated inside Providence, we saw the rise of digital health. There'd be apps that would help manage XYZ, and the payers and employers have far more and direct to consumer. Consumers going to the app store and downloading something that helped them in their weight loss or their nutrition management or their stress and anxiety. Those different channels have adopted digital health more rapidly than hospital systems. Friction of EMR integration, business model incentives, et cetera. When we work with the hospital system, we manage their digital health formulary.
Yep.
And their formulary does not necessarily overlap directly what a payer or employer might have. Payers and employers look for prevention methods. They focus on chronic care management. They try to keep people out of hospital systems.
Livongo specifically.
Yes, and hospital systems will focus on procedural efforts. They will almost always adopt a maternity care app. They will almost always do surgical prep and the PTOT recovery on that and digitizing that pathway. Increasingly, they're doing behavioral health, but when you get into like broad-based chronic care, the hospital systems don't have the financial incentive to prescribe something and then get paid to monitor against it, and who's paying for that. So what needs to happen is a little more alignment of the payer reimbursement around chronic care and the clinical hospital operations. Because one thing that we do have is 4 to 10x higher adoption when it's that doctor recommending something to a patient than the employer recommending something to their employee base, or the payer even like suggesting like, John, you really need to manage this, and people don't trust insurance. Why are you trying to get me to do this? But if the doctor says that, people will more readily accept and adhere, especially when they know that clinician is looking over their shoulder at the data stemming from that app or tool or program to know if the patient is being adherent to that. So there's a little bit of a sentinel guilt factor that creates a greater adherence concept when the clinician is the one recommending that to the patient.
Yeah, so I mean, obviously the patient-provider relationship is the most trusted within this ecosystem that we're talking about. Nobody trusts the payers to necessarily have their best interests in mind other than cutting costs and making sure that they're not going to get sicker.
That said, they're doing good things.
They are,
and they're
but we don't trust them as consumers usually. That's the issue.
Right. No, that's true. And they focus on prevention, which ultimately should be the goal of all of us: better, healthier lifestyles. And if they'll pay for healthy, fresh foods, and if they'll pay for these preventative measures to prevent a surgical operation, that's net a good thing.
Oh, absolutely.
So that's what we need to find, is a little more balance between what payers might incent their members to do and what hospital systems want their patients to do in better care and maintenance and healthy lifestyles.
I think payers also need to do some more to regain that trust of patients, because there are a lot of great payers out there that are doing really good, innovative things, but there's just this backlog of mistrust.
Yeah, well, the whole world is bleeding because now payers are getting to more clinical care delivery, and there's more virtual first primary care, and that's encroaching upon traditional, hospital and care delivery models. So as the world matures, you're going to start seeing more blending of payer, provider, risk-taking, capitation, et cetera.
What have you learned about the adoption or the uptake of some of these solutions that you maybe weren't expecting hospitals to be as interested in as they have shown to be?
Well, because we prescribe and then monitor the usage of that, we've got different analytics. So we can, in prescribing something, we can do a manual click, John, I'm really sorry you're not feeling well. I'm going to prescribe this app to you, and I'm going to be able to monitor you remotely and see if there's any, negative signals whereby you might need to change your meds or whatever.
Yep.
And if the clinician has that face-to-face recommendation with the patient, 80+% engagement rates, adoption, deployment, adherence to it. If it's on an automation routine where every time we see someone with this diagnosis, let's push something to them, and the clinician's not specifically having that conversation with the patient, then you start, dropping off 20, 30% on some things. So automation, which, reduces workload and burden, et cetera, is great. You can meet, mass market everybody if it's a conditional profile, but you're going to have a drop in the acceptance and take rate and adherence rate. So that's kind of one level of discussion. Maternity care adoption, a pregnant mom engaging in an app to, track the baby's fetal development and massive uptake. A pregnant mom is an engaged mom in the health and welfare of that child. Smoking cessation, you're going to tell me to quit smoking again? But still, we've 10x the number of smoking cessation enrollments. 10x is massive, yet it's still in single-digit take rates. It's not like it's not the 80% pregnant patients, adopting something. You got 2% conversion of the smoking cessation. Another one is advanced directives. Having an advanced directive on file, DNR, it's important, end of life, not getting to the invasive procedures, and a massive cost savings for the healthcare industry. But it's a tough discussion, for a primary care, clinician in an appointment like, John, let's talk about your mortality.
Yeah.
You really need to fill out these forms, bring them in next time.
There's no standard to start that conversation these days.
Right, so we automate that. Every time someone comes in for an annual wellness visit, they're over age 65, don't have an AD on file in the EMR. Hey, John, you're coming in Tuesday next week to see Dr. Steve. It'd be really important for you to consider having advanced directives on file. Here's educational material. Here's links to download the forms. We really hope you take the time and effort to bring these in on Tuesday. And so we, again, I think we 15x the number of advanced directives on file in the EMR. And when the patient comes into that appointment, the clinician knows in the encounter notes, John, you downloaded the forms. Did you bring them in? Or John, you watched the video. Do you have any questions? Where should we start this conversation? So just let some of the repetitive burdens of some of this low-hanging fruit, smoking cessation, advanced directives. These are manual processes and let me get those photocopies out of this file. You bring it home, you fill it out. If you can just automate a lot of this stuff that's helpful in the administrative side of care, that's also a significant burden, time savings and net benefit to a patient, in as much as a care disease, management protocol, or, following the correct surgical procedure steps before you come in for the day of surgery, et cetera.
Okay. So I guess wrapping up, is there anything else that you'd like to share about what you're doing with Xealth, or what excites you about healthcare in general, what you're seeing here at HIMSS that's piqued your interest or surprised you?
Well, I came into healthcare to make a change, and I want to do so at scale. And we're now working with over 20 hospital systems, and these are the largest ones in the country. And I want to be ultimately the benchmarking of digital health effectiveness, knowing what apps, what tools, what programs, on what intervention, routine or protocol produce the most effective results for patients. I mean, I jumped into, I had success in some past companies. I wanted to make a change in healthcare, improve the health, welfare, and society of the US population. So that's what I'm pursuing. My hospital customers are great partners. I am in fact presenting in an hour with Duke on a number of the case studies that we've done with Duke Health on engaging patients. We've reached 100% of their patients with different digital assets, tools. Some of
That's really impressive.
Some of it's patient education, some of it's COVID awareness, some of it's how to schedule a telehealth appointment and teach all their patients how to do telehealth in this times of COVID. But Duke has been a fabulous partner, and so that's something that if you're free in an hour, come up and hear the co-presentation with their chief digital officer and myself.
Okay. So actually, building off of what you were just talking about, one of the things that we were speaking with someone yesterday about is this need for better digital literacy in our country. So it sounds like that's something that you're also working to address.
Yeah, and we have sent out material that is sort of targets the different patient populations with their level of educational interest in that product. It speaks to their level of depth in that material. Is it deep oncology level data that gets really, really in depth, or is it more generic, grade school educational level, material.
Yep.
Some of our hospital customers have rural populations. One even said, we have an average of, 4th grade reading level across our population. Like, holy cow. We don't even have a patient education vendor. We do video.
Okay.
And so
video is really good.
But that was tragic. That was sad for me to hear. I had never even, kind of contemplated that. So how you reach a patient population that's meaningful and engages them and speaks to them on the level that they'll understand, the health, the benefits, the consequences of not taking care of like some of their, their healthcare needs and preparation and healthy lifestyles and maintenance. We've bridged into a lot of social determinant of health.
Yep.
We've done a number of meal delivery programs for patients, post-bariatric surgery, how to get started on a healthier, eating lifestyle, post-surgical operation when you don't have a caregiver at home, having some fresh, meal delivery for you to start off on a recovery, plan and pathway. We've done transportation. We've done a number of product recommendations. And so, I think that's what we can facilitate is bridging a digitally facilitated health. Not that meal delivery is digital health, but we help digitally facilitate that.
Yeah.
That is for the benefit of patient care, but it still needs some technology and automation and clinical recommendation logic, which is what we provide for hospital systems to enable better patient care.
Fantastic. That's a really good mission. Sounds like you guys are on the right track. So in closing, is there anything that you'd like to say to our audience about how to get in touch with you or to reach out?
Xealth.com. Thank you very much. I appreciate everything, John. As always, great to talk with you. And I would love to work with your hospital systems and the number of vendors that you think would be appropriate for better patient care. Thank you.
All right. Well, this has been an interview with Mike McSherry, the CEO and co-founder of Xealth. Thank you for joining us today. If you liked what you saw here, please remember to subscribe to our channel and throw the video a like. Have a great day.